We're going to continue on with this discussion, and I want to bring up our next moderator for our following panel. It is Dr. Samantha Kaplan. She's an assistant professor at the Department of OBGYN and Assistant Dean for Diversity and Multicultural Affairs at Boston University School of Medicine. She is a good friend, and she is also a past Commonwealth Fund Fellow, also graduating in 2008? 9, that's right, because you interviewed me. That's right, and received her MPH from Harvard School of Public Health as well. With that, Dr. Kaplan.
I'm going to stand to the side just a little bit because I'm so short. So we have heard about systems-based interventions that can impact specifically maternal mortality and morbidity in the perinatal period, layered on top of a conversation about statistics and data gathering. And I think one of the things that really stood out for me in Dr. DeClercq's comments in looking at some of the causative agents was that big area that was attributed to community. And so what we're going to talk about on this panel is the community-based interventions that can be made and ideas, opportunities that exist for us to begin to mitigate some of those disparities beyond the walls that we can control or that we think we can control or we try to control as clinicians or, I would say, administrators. And I think a lot of what we're talking about in the community falls under that umbrella of what can be done in public health. Some of public health is programming, some is policy, but some of it is actually directly interacting with the public around health. And so that's what we're going to hear about from this panel of experts. I am going to let you know we will have time for questions, and at the end we will have commentary on both panels. So I will try and keep my thoughts limited, although I have one reflection after listening to the first panel and this panel, which I will share at the end, if it doesn't come up. I also am not nearly as social a being as Audra, so I have very little personal information to share, but I think we have fantastic panelists from the brief interactions that I've had with them, and I'm going to tell you a little bit about them. I think the order that our panelists are going to present is also important because it's really going to bring you into a greater understanding of how important the community and working with community is. So we're going to start out by hearing from Nneka. Nneka is a full-spectrum doula. She is the mother of 4. She has an 18-year-old, a 13-year-old, a child who would be 8, and a 4-year-old. She is a whole woman advocate who works with women across a full spectrum of their life and their life phases, specifically looking at pregnancy and infant loss and maternal mortality within the African-American community. As a full-spectrum doula, she is an international bereavement specialist and a community-centered herbalist and a womb health advocate. She is also part of a number of very important community organizations. She's a member of Vital Village, Boston's Community Action Network, Boston's Breastfeeding Coalition, and This Is My Brave, and she was featured on This Is My Brave in January of 2019 within the documentary. She's going to talk to us today from both a personal and professional perspective on the importance of support of women to impact perinatal mortality, and not just specifically when we tend to think about it within the period of birth, but in a much broader view in the antenatal and postpartum period and how that can impact mortality for women.
One second for technical. Okay, awesome. I normally don't like working with these things because I'm not a very tech-savvy person, so bear with me, and we'll get through this. First, paying homage to my ancestors who have somehow managed to fill the entire month of May with speaking engagements. However, when I received the email from Ying inviting me to speak here, I thought it was a prank from one of my older children or a dear friend, and I'm so happy I didn't press send on the initial response I had written. But more seriously, as a young girl one of the first words I learned was statistic. I somehow became fixated on it and prayed that I would not grow up to be one. I honestly wished someone would have informed me that because of my color, the color of my skin, or my ethnicity, it was my birthright. On August 26, 2010, I was blindsided by a statistic that I should have known about. At 39 weeks gestational age, my daughter died, and my OB comforted me with 3 words: these things happen. August 27, 2010 was the day my daughter arrived earthside. It was also my 37th birthday. My year of fog began. August 27, 2011, I looked at my children, who were then 11 and 6, looked at their faces as they screamed, sang happy birthday to me and their sister, who should have been there to celebrate with us. They were pleased and I wasn't. I faked a smile and was able to contain the tears until I ran out of the room. But tears are cleansing, and for the first time in a year, I was able to see a little bit through that fog. I needed answers, and for the first time, I found the strength to review my medical records. I later found a doctor who was able to decipher the medical jargon, because clearly I had no idea about the chicken scratch or terminology, what have you, and discovered that I should not be here. You're looking at a ghost. I'm a ghost who was reborn on her 37th birthday. I complained about my daughter's actions and my feelings throughout my entire pregnancy. And sadly, because of my history with depression and marital problems, I was sent for a psych consult. Proteinuria was labeled as an unclean catch for an entire trimester. A slightly raised blood pressure was just looked at a normal blood pressure result. And as a result, my daughter passed away. Cause of death, asphyxia. Now I can close this and really talk to you. 2011, I became a doula. I thought that I would be able to work with others and sort of bridge the gap between, between lay people such as me and moms who look like me. I could tell them things, learn the terminology that I could not understand at the time. And mind you, at the time of my loss, I was the mom of 2 already. So I'd already experienced the pleasures, the joys related with having live births. And now I can look back at the birth of and this is my rainbow baby, my 4-year-old. I can look at the death of my daughter as being my rebirth, because now I'm able to focus on helping others and make sure that they know a little bit more and they're able to use their voices and to be heard so that they can be heard. I realize as a doula, I'm not allowed to speak for them, but they are allowed to speak for themselves. And I just have to credit the slides that I'm using came from one of my sister doulas in Connecticut who said, oh, go ahead and take that information. It was just easier to use their jargon that they're using for their doula bill than to recreate my own. So you can see here, what is a doula? Everyone here who has given birth, have you had a doula? Does anyone, before this definition, did anyone in here not know what a doula was? Yes, no. Ooh, great. This is the first room I've ever been in where everyone knows what a doula is. So, doula care increases the likelihood of a shorter labor, a spontaneous vaginal delivery, higher APGAR scores, and a positive childbirth experience. Now, I had never heard of a doula before 2011, and I happened to stumble on the term and had to know more. See, that's my problem. I have to know too much. There are times when my children say to me, come on, Mom, just accept it for what it is. And I'm not that type of person. reduces the likelihood of costly interventions, reduces spending on non-beneficial medical procedures, avoidable complications, and preventable chronic conditions, improves health outcomes for both mothers and babies. We also bridge the gap between community services, so we can go into the community. We partner with community organizations such as Boston's Community Action Network. Anna and Namisha are here to support from the Community Action Network. I'm proud to say that in our most recent All Can meeting, we found out that because of our work since 2011, the infant mortality rate has dropped by 37%. And currently, the CAN is working on a FEMA bill, as well as preconception health, a variety of preconception health things. Most recently, we're working on interviewing African American and women who identify as Black to see how the community relates to them, if they feel like they're being judged, if they're being spoken against, or what have you. I'm sorry, I got to get through these slides. Patients who have hired a doula reported feeling valued, having had a voice in consequential childbirth decisions. We slow things down. We translate. We're there for them before they get pregnant, during the pregnancies, as well as that first 40 days postpartum. Now, at least I am. I had the opportunity to travel to New Mexico in December and take the best training in the world, NH Traditions Postpartum Care Training. If any of you have the opportunity to take that training, it is also an online training. I know most of you have spent your lives and most of your money becoming doctors. However, this will put things into a different frame for you as birth and postpartum providers. It was a life-changing experience for me. I hadn't seen the postpartum phase so eloquently supported, and it taught people from different socioeconomic statuses how to provide support in their communities. One thing that I would like to say in closing, and I'm sorry, there are several organizations that you guys should become familiar with. Even within the hospitals that you service, there are doula programs, volunteer doula programs, that your clients, if they don't have the support, should be referred to. I've had clients who could not afford my fees, and I said, well, why are you trying to pay me when there's a volunteer program? Well, what happens is, if you're not coming in on Medicare, they don't refer. They assume you have the money to pay the $1,500, $2,000, $2,500 fee of the, for the doula, when that's not always the case. So look into your systems to see how we are there and who we are. Oh, I have 2 minutes? Oh, okay. How we are there to support you. Also, we have the Birthing Project USA, which sets up systems of community kitchen talks in churches and community centers that can be formed just by talking to grandmas. They come in and they provide support from conception through the first year of life. And they come in and they support the families as doulas if they cannot afford a doula. We also have Bridging the Chasm, which is a new program that should definitely be looked into. There are several different work groups going on now. And these are people who are from all over the United States who are coming together to figure out why this is happening, why mothers and babies are dying. In the Boston area, I love the Smart from the Start program. If I have a family who definitely needs the community help, I refer them to Smart from the Start, which has several different locations, and they provide support from conception through age 1 and also beyond. What they do is they pair them up with someone in their program, and they walk them through their pregnancies. They make sure they make their doctor's appointments, they make sure things are understood in lay language, and this is crucial, especially for people, and this is a program for low-income families. I'm saying the entire family unit, not just mom, because we focus on mom during pregnancies when it should be the entire family unit. And if mom is a single parent, they help to provide that excess support by linking them to other community supports. And this is my angel baby, Anaya Marie, who would be turning 9 in August. This presentation is in memory of all mothers and babies who have died before birth and in the year that has followed. Thank you.
So our next panelist is going to talk a little bit about the community from a different perspective. She's an assistant professor at the American International College at the School of Health Sciences in the Public Health Program at Springfield and an adjunct professor at Holyoke Community College. She is currently president of the board of directors and the executive director of Mother Woman. This is Dayna Campbell, who also is in the process of pursuing her PhD in health services, policy, and management at the University of South Carolina. So very busy, and is going to talk to us today about community-based participatory programming. So this is what we all learned when we were getting our MPHs, is a critical way to make sure that what you're doing is not to the community or for the community, but with the community, and perhaps you even invite the community to be involved in the programming themselves.
What wasn't mentioned, in my spare time, I'm raising a 6-year-old daughter. So again, my name is Dayna Campbell, and so I want to tell you a little bit about Mother Woman and the programming that Mother Woman has been doing to include community and identifying the concerns of community and involving community and actually coming up with solutions or addressing those kinds of concerns. Just a little bit about Mother Woman. It started in 1999 by a few women in the Hampshire County area of the state. Some of you might know where that's like Hadley area, Amherst, Northampton. And it was to address the lack of resources for postpartum moms, particularly as it relates to mental health issues. Both could be PPD, anxiety, could be just baby blues, or even just social isolation. And they came up with a model for creating a peer support group and trained lots of people on this method. And so then in 2004, it became a 501c3. And then, it's just much like any nonprofit, they had their ups and downs. And in 2016, there were some major changes to the organization. I was asked to come on to the board in December of 2016. And then the organization moved from Hadley, Massachusetts to Holyoke, which is somewhere in between the urban-ness of Springfield and sort of the ruralness of Hampshire County. And then in the midst of me starting out as part of the board, I started asking questions. I think the researchness of me came out, and I asked, what is the data? Like, where's the data? What research have you done? How is this getting to vulnerable populations? Who are you training? Is this accessible? Who's sitting on the board? And then next thing I know, I blinked and I became the president. They voted me president. And I had time to do this. But anyway, that's what essentially happened. And so I asked a few of the people that remained on the board to come along with me on a journey to sort of rethink how we are approaching these services that we are providing to moms or potential moms. And so what I'm going to present to you is sort of a combination of using what was already there and then where we're hoping to take the organization. So these are sort of the 3 tiers of things that we sort of visualize. Oh, I forgot to tell you. Let me tell you the mission. The mission, it's still a work in progress. We have changed the mission and probably will change it again. But right now it is to promote the resilience and empowerment of mothers and their communities by building community capacity and advocating for just policies through evidence-based research and grassroots organizing. And so this slide shows you the 3 tiers of what we are attempting to do. The first being community capacity, building the capacity to actually address the needs of moms, and doing some research, which I will explain a little bit about our project called Mama's Voice. And then Mother Woman has historically been involved in some advocacy projects, including the very last one, the Pregnant Workers Fairness Act, which actually was started through conversations from Mother Woman by a woman named Laura Sylvester, and we successfully got this passed. I hope you all have heard about it. Your employer should have told you. So starting at the bottom in the community capacity is the facilitator training, which is what I had mentioned before, and this is training anyone who is interested in running a support group, and we have a model for that. And it can be for, it was started primarily for PPD, but has been expanded to a wide variety of areas: teen moms, women in recovery, women in prison. I mean, just, whatever the needs, bereavement, special needs, those kinds of things. And then if you move up, one of the things that we noticed in doing some of our work was that many of the providers that are, there's not a lot of providers who are doing evidence-based therapy to address PPD or postpartum mood disorders. And so cognitive behavior therapy is one of them, so we started offering that training. And then we also recognized that, at least in the western part of the state, that a lot of the providers did not look like the people who needed the assistance. So we started to really think about ways in which we can recruit providers of color, LGBTQ, et cetera, to provide services. And then I wasn't going to talk about this before, but based on some of the conversations earlier, I thought including a rich conversation about cultural humility. Some of you may or may not have heard about cultural humility. It is a philosophy in which, or a philosophy or / a tool to look at the relationships and the interactions between providers or service organizations and patients and their clients. And it comes out of work out of Children's Hospital of Oakland, two pediatricians out of there, Dr. Melanie Turvalon and Jan Marie Garcia. So if anybody's interested, I can give you a little bit more information about that. But one of the things that we had decided is that we were going to focus on vulnerable populations and disenfranchised populations. And so cultural humility has really taken on a huge role in our work, and we are committed to being a culturally humble organization, or at least be on that journey. And so we also provide trainings in that. And then the CPPSM is the model that we're using to bring together groups of people to work on perinatal issues and support. So I'll talk about that. And then our evidence-based project is Mama's Voice. So this is the original CPSM, and there's 12 coalitions across the state. Some are operating really well. Franklin County has a very successful coalition. They have actually leveraged their position to receive a $1 million grant to do some work in the prisons. And then there are some coalitions that are not doing quite as well, but we're hoping to receive some funds to help those coalitions. But this was the idea. That's the model, and it's sort of circular, so that You bring leaders together, you do some training, you provide technical support, but the whole idea is to get moms screened for PPD and then into treatment. And we had decided to change the model a little bit and add a couple of components. And so these are the three. The first one is making it more community-based. And so when I came on and I started looking at the coalitions, I recognized that it was provider-heavy. So whether it was OBs, whether it was midwives, doulas, service providers, and less people who had a different kind of vested interest in that, in the issue. And so we are reaching out to the coalitions to say, hey, you need to really think about how you can bring moms onto your coalition so that you can stop providing solutions to and asking people what they actually need and coming up with solutions with. And then I mentioned the cultural humility. Again, we are providing training so that anybody who's sitting on these coalitions actually know how to interact or use this as a tool to interact with the people that they're providing services to. And then the last one I'd already mentioned is that we have noticed that we lack the professionals to address the issues. Okay. And then the last thing I wanted to talk quickly about is the research project that we're working on called Mama's Voice. And voice is voicing our individual cultural experiences. And this is actually a photo voice project. I heard Dr. Clark make the comment about not using qualitative, which I thought was kind of funny because this is a qualitative. But it is a photo voice project that we have been, this is about 1.5 years that we have been working on, where we're asking moms in the Holyoke area and the Springfield area to provide photos of what it means to be a mom of color in those spaces. And I presented at APHA the results of our second round last November. And so if anybody wants to hear any more about that, I'd love to talk to you about it. But it is very interesting to see the ways in which people experience the regular stressors, but then there are some that are very culturally based that are often not addressed. And I think this is one way to sort of identify that. The other thing is we thought about looking at how can we redefine what it means to have mental health issues as a mom of color. Maybe it's not PPD or anxiety, but maybe it's high levels of stress that, and I think you all know this, but that affect not just our mental health, but our physical health as well. But how is that captured on a screening tool that's only looking for depression or anxiety or OCD? And so this tool, this process, we're hoping to be able to redefine what it means to have some issues that need to be addressed. And that's it. Thank you.
So, sort of circling back to one of our organizations here in Massachusetts. We're going to be hearing from Karin Downs, who is the Maternal and Child Health Director for the Title V programs in Massachusetts and the Director of Pregnancy, Infancy, and Early Childhood within the Massachusetts Department of Public Health. Including and outside of that spectrum, she's been doing work here and internationally for over 40 years, focusing on providing support to women and their families to ensure optimal health and economic outcomes, and attempting to address the social factors that contribute to maternal mortality and morbidity, and the inequity. She's very interested in strengthening a system of care that addresses the social and racial justice that that dismantles the structural systems that have led to our current situation, and trying to ensure that women and their families, again, families are very important, receive all the support that they need, antepartum, peripartum, and postpartum.
So, good afternoon. I'm in a great position of following on a lot of people who have really laid the groundwork for some of the things that I'm going to say. I wanted to say that although I work at the state level, what I really feel that I'm doing is trying to bridge the community, the chasm between the community voice and policy and the state level. So although we work at the state level, much of what we do really has to be and must be grounded in the voices of the community. And I think we've heard of that from many people, starting with Gene DeClercq and his Listen to Women, which was number 3 of his. And also Dr. Molina really spoke to the need in a clinical practice to be very mindful of how we speak with people. And, looking at implicit bias, I want to add to that implicit bias piece, really understanding power dynamics within a room. That is critically important. And I'll talk to that a bit more later. And with that, I'm going to figure out how to press forward. Enter. There we go. Got it. So I'm going to talk about 3 community strategies that we use at the Department of Public Health to really listen to community voices. The first is we have some federal funding and a little bit of state funding to provide home visiting services to pregnant and parenting families. The first is funded through the federal MCV, which is Maternal Infant Early Childhood Home Visiting Program. And we've used some funding from MCV to also implement a program called Welcome Family, which is a one-time postpartum universally offered home visit in certain communities. And the third one is a state, what we call, the feds have this, the federal government has this, they have evidence-based, and then they have this affectionate term, a homegrown program. So the EIPP is our homegrown Massachusetts version. The other piece I want to talk to a little bit more is community network mapping. I mean, how do we look at the system of care from the community level? And we have a very structured approach that we're hoping to use across multiple programs. And then the Title V needs assessment, that is, and I'll get a little bit more into that later, but Title V is Title V of the Social Security Act that provides funding to all states to support families and children, including those with special health needs. So, home visiting. I think the goal for home visiting is really to be that link, that liaison between the medical system or the system of services and with families. Home visitors in most programs they're either community health workers, one of the models, EIPP, which I had mentioned. There's a nurse and there's a social worker or a clinical specialist that may be a mental health specialist. And then in some, they're peer moms in recovery, for example, in some of the home visiting programs that are more specific to families affected by substance use. So what happens in the home visiting, I think the point is to really meet families where they are, to really hear and understand what their challenges and issues are, and to really promote a different paradigm, rather than them being those people or low income or people who need help, really support them starting from where they are, listening to their stories, and really looking at reframing and taking more of a strength-based approach. What have they done well in the past? How can they be positive parents? What do they need? What is their understanding of how the system has treated them, and how can they really sort of walk along the sides, similar to what Nneka was talking about in terms of a doula. That is the role that a lot of the home visitors play. And when we were thinking of the home visiting, and I also wanted to circle back to one of the questions, a huge part of the home visiting program is really speaking with families after they've delivered about their intentions for having another child or not. And even 2 or 3 years out, the question is always, do you have the intention of being pregnant, and then support them in whatever their decision is. And that is one thing that's a critical part of our home visiting program. So, but this is not usually where we talk about, this is the immediate postpartum. These visits take place between 4 and 8 weeks postpartum. And we only have enough money at this point to universally offer this in 5 communities. We're hoping to figure out a mechanism to sustain this because we've had a lot of really positive feedback. So what people have felt is that this is a point of intersection between giving birth and the rest of their lives. And when they're pregnant, a lot of focus is on the pregnancy, and then the baby, and then the baby's born, and then suddenly the woman sort of drops out of view. So we really wanted a program that focused and supported the woman and tried to figure out what she wanted and how to support her in parenting. So you can go look at some of the research, and we were identified as a promising approach, and we have written a couple of articles. And at this point, I really think there's a lot of value in thinking about this as a potential policy initiative across the state. Oregon has just passed legislation that provides a universally offered 1 to 3 visits postpartum, and that's part of their early childhood bundle, if you will, in Oregon. So we're hoping to learn from them. As I said, I can't start in the community without thinking systems-wide as well. So what do we do at the community level more specifically? One thing we realized when we often went out to the communities and talked to them was that we were encouraging families to participate on community coalitions or to join advisory groups. But what that didn't recognize, I want to circle back to the idea of the power dynamic. What we found often was that we had tokenism on these advisory committees and on these coalitions, and we really wanted to be a little more strategic about how we formed a coalition. And so what we're doing in one community and hoping to replicate it in other communities is that we really start first with families with lived experience in a network mapping exercise that, from their perspective, asks them what about their journey through the system of health, the healthcare system? What worked? What didn't work? What was helpful? What wasn't helpful? This particular network mapping we're doing with families in recovery or with substance use disorders, specifically opioid use disorders, but it could be applied for any experience. And once they have done their network mapping and we have looked at what are the challenges, then we sort of encapsulate all of that and ask which of them would like to be community leaders and speaking out on what their experience was. And soon after that, we do a provider and community leader network mapping, which is interesting because usually it looks totally different from the family network mapping. And so the families will have their perception of the systems. Then we'll get the providers, and the more diverse the providers and the community leaders, the more rich the network mapping is. And then they will come up with their solutions or their ideas or their trigger points, things that aren't working. Then we bring everyone together, and that's the point at which the real dialogue and coalition building happens. At that point, we ask people to talk about shared vision, who's going to be the backbone organizations from both perspectives. What would be the indicators of success, and how can they align their activities? And one of the most critical pieces is having a communication structure. And then after that has coalesced, and there's a coalition that has come up with a strategic plan. Then we have learning collaboratives across the state so communities can really learn from each other. And I thought I'd have all the time in the world, and now I'm really having to go quickly. The Title V needs assessment, I'm not going to go too much into discussion about what Title V is, just to say that there is a very strong quantitative part, which Fifi, my colleague, leads, and then there's a strong qualitative part. Before I was in public health, and before I was a nurse, I actually was an anthropologist. So this is back to my roots. And what we do in our needs assessment, every 5 years we're required as a part of the funding to conduct a comprehensive state needs assessment that then dictates what our state priorities are for the next 5 years. So that's a huge task, and we want to get it right. And we want to look at the data and look at trends, and we interpret what might be happening, but what we really want is the voice of communities. And so we have a whole series of focus groups. Some of the ones that we had the last time around, we're just gearing up for our 2020 needs assessment now, but in 2015, we spoke with moms who had given birth, moms of color, Hispanic groups. We had a great LGBTQ group, and in these groups is really fun. Nobody has to use their real name, and everything is de-identified. So the LGBTQ came up with the great, we had Mickey Mouse, and we had all kinds of people on that team. Incarcerated parents, their perspective is invaluable. If you talk about people who are most oppressed and most disenfranchised and most disconnected from their families, I would say it's the incarcerated parents. And teen parents. So in addition to the focus groups, we do surveys, and we use all of this information, we collate it to determine our state priorities. And the one thing I want to say that happened, I'm not going to go into what our state priorities are. You can look them up. Title V information system, look up Massachusetts, and you'll see all our priorities. But one thing that really came out strong and clear from the series of focus groups, from every single focus group, was the need to address racism. And, I had teenagers stand up to say in focus groups, I am not standing for the Pledge of Allegiance until there's liberty and justice for all, and I'm not seeing that. And, it just gave me chills just to hear how this was a consistent theme. And because of that, one of the priorities that we set in our state was to really address health inequities by addressing social justice, racial justice specifically, and leading with race in everything that we do, in terms of even looking at the data, looking at what our policies are internally, and looking at how we can really frame the principles for the contracted vendors in our states. And I think, okay, this is one of the groups. This is an actual real picture. And that's how you can get in touch with me.
I was thinking when I had the opportunity to moderate this panel, yes, I'm an OBGYN, and yes, I do this every day, and yes, I work at Boston Medical Center, but what are my own individual thoughts about this, and why would this make sense, particularly this community element? And I think, there are a couple things that I want to mention very quickly that I think were touched upon that I want to highlight so that they are addressed in questions and perhaps in commentary by Dr. Bryant when she comes to speak. I think centering, although I did hear from Karin, I actually was at a talk that with she and Fifi were on a Monday night last week, I think. Centering has not been shown to be as effective as we would like to think that it would be in affecting outcomes. However, as someone who's done centering in pregnancy for the last, 7 or 8 years, I would say I think that in addition to learning your patients well as providers, there is a middle tier of community that is created amongst those women that can oftentimes help to supplement whatever the community is and serve almost as a group doula-like experience for some of those women, because there is support that we see before delivery and even extending beyond delivery within that community. And I've had centering groups where people come back, 2 women to the same group several years later, who stayed in touch ever since between their pregnancies, which I think is extraordinary. The second thing is I wanted to just mention this whole idea of interdisciplinary approaches. So we, yes, should include family planning, and in fact, one of the fellows at Boston Medical Center, the Family Planning Fellows, is looking at the impact of racism on women around reproductive choices beyond pregnancy, such as contraception and abortion and spacing. And does racism disempower women, and what are the stressors and the expectations within society related to race for women as they make these choices? But don't forget, as OBGYNs, we lose women. They leave us and they go see primary care doctors, or they go see they see other family medicine doctors, or they don't see anybody until they come back and they're pregnant again. And we have not yet figured out how to include that discipline, whoever that is. And that is many people. That is some emergency medicine doctors. It's some internists. Sometimes it's the pediatricians who are talking to the mothers when they're seeing the children. And we have yet to even begin to explore that. And I think that's another dimension. Questions for our panel? I have a question, and then it looks like you have a question too. But so this is in keeping with what Dr. Molina was talking about in terms of concordance. So this is specifically for you, Nneka, in terms of, do you think it matters that there be racial, cultural, ethnic, experiential concordance between doulas and patients, and how does that impact the discordance that we see given our health provider workforce, and I'm going to include midwives in that because there are not a lot of midwives of color either, actually, and our patients that we are currently discussing here, our patients of color?
Well, I think the second part of that question can be answered by looking at who is actually in the room today. Look around. First portion, I think walking into a space and seeing a doctor that looks like me, or a midwife that looks like me, or a nurse that looks like me, I'm more open to tell them the truth about what's going on with me, regardless of whether I'm going to see an OB. Case in point, my fourth pregnancy, my rainbow pregnancy, I had the pleasure of having Dr. Laura Riley. And I thank God I was 41, because I probably would have gone back to her a few times before she switched I would have just gotten pregnant for that experience. Seriously, I mean, it was the best experience ever to be cared for my birth plan to be taken as Bible, to negotiate my 37-week induction. I went to her knowing more than I've ever known before, because with the first 3 pregnancies, I didn't even know what a doula was. That was the only pregnancy that I was aware of how my body worked. And I think that's another key, teaching our women before they get pregnant how their body works, going into our communities saying, this is what a doula does, this is how she can, or he can, provide support to you throughout your pregnancy, and so on and so forth. As a person of color talking to another person of color, this is why I became involved with the Community Action Network. I've been involved with them from day one, pretty much, from the first year of inception, and I plan to be with them until they're no longer there, because I look around and I see a beautiful rainbow. No one is belittled. Everyone understands, and if they don't understand, there's someone there who can explain it to the fullest. We have all come together, even with planning the mission, planning whatever. There's no one person making that decision for us. It's a true community, and what a community should look like and be modeled after. Did I answer?
I think so.
Okay.
Samantha, could I also say something?
Absolutely.
One thing I had meant to mention was, even in research or doing focus groups or the needs assessment, it's critically important to have people who are running the groups mirror the communities or be part of the communities. And so one thing we're doing this time that we're doing the needs assessment is really training community facilitators in running the groups. Last time, I love being in those focus groups, but I'm white, I'm old, it's like, I think that I'm not that old, but I really believe that having this concept of participatory research, as well as, similar to what Dayna was saying about participatory program development, is critical, because we're not going to really know what, people may not speak with such authenticity and may not feel that they can speak truth to power, when power is sitting right in front of them, so much as they can really talk about their experience with people who they feel that commonality with. So that is something we're really excited about doing this time, is really training the community researchers.
Do you want to make a comment?
Yeah.
Go ahead.
Can I just make a comment? For recording purposes, you just need to go to the mic. I think I'm still concerned that we have to choose where we go for care, try to find the people who look like us. In terms of the population in the United States, we have 80% or more white and less of the other groups. So the workforce itself will never mirror the population to the extent we want. When you walk, I was giving a talk at the UMass Medical School. I was shocked that there were only like 2 African American students in the classroom. There were like over 200 people. So we are not allowing enough of the African American people or other people of color to be in the schools to begin with, to be in the professions. So the expectation that we would see them is kind of making the choices difficult for us. It would require that you travel from your town to the town where you can find a nice Dr. Meadows to give you a hug when you walk in her office, or not to go at all. We do see people who decide not to go at all, right? I think we need to be in a place where we can freely walk in any hospital or community health center, knowing that we would be cared for like a human being. Physicians, we swear, when we finish that medical degree, we've completely forgotten what it is to not cause harm, which is what we swore. All of us have. So I think the conversation should go back to how do we create a space in our services, hospitals, community health centers, everywhere, where people can come and feel safe. Because at least as far as I'm concerned, you call the hospital a place where you go to feel well. It's a place where we get well. How can we not provide that? I think it's pretty simple. We've forgotten the basic human right and why we're physicians. It's either you like the profession, you do your job, or you don't. So we need to restate the conversation. And the other comments is related to the one key question, which has become pretty popular. In some communities, reproductive health is a private matter. When I have sex and when I get pregnant, that's my business. It's none of your business. So not everybody is open to having those conversations. From a religious perspective, in some religions, like Muslims, they're required to do whatever, to be a good wife. So having the conversation in a different way might help address the problem. You can't just tell them, when are you planning on being pregnant? When are you going to have sex? No, hell, nobody knows that. So I think we need to think about how we do that conversation. I know it's awkward coming from an obstetrician, talking about family planning, but it's a reality. It's something I learned from the patients. So I just wanted to put that out there, too.
Can I respond to that? I often say to my daughter, I'm not that kind of doctor, so I'm not going to speak for a physician because I'm not a provider. But one of the things that I've learned in cultural humility, particularly coming from providers, is finding some kind of tool or philosophy in this case that you practice and how you interact with your patients. And so if you are interested in it, I would tell you to. Does anybody, y'all have heard of cultural humility? Some people, okay. So, Dr. Torvalon is and I think she's coming to Boston in October, by the way, to do a training. So I don't know who's sponsoring it out, if you want to find that out. But I think having those conversations and learning how to address the power imbalances. I watch my grandparents, for example, go in and not ask a question at all because there's this sense that the physician knows all, and who am I to question, even if it's me, even if it's my body. And I think a lot of people have that. And what ends up happening is if we're the authority, we take that power on. And we need to learn to mitigate that power. And some people do it better than others. And I think that also is with service providers, right? I think it's not just in provider-patient relationships. So that's one of the reasons, I really like cultural humility, because I think it's a really good tool to really step back and think about, who you are and what do you bring to the table, and then how do you address other people, even if you are in a power position. Because you're right, every place that we go the person's not going to look like us. And so I have to know, as an African-American woman, that the person on the other side is going to follow some kind of strategy that is going to make me feel comfortable or as safe as I possibly can feel. But I don't know that. I have no reason to think that even.
Thank you. This was an enlightening panel. I have to say, Karin, you enlightened me on something that I really didn't think about. I like to say often that our state PQC is the formal bridge between the clinical care system and community, and not community, public health activity. And the way you brought it up around home visiting, it seems like that's a natural one. And I have two questions, one for you and one for you, Nneka, on this issue. And that would be, in the structuring of home visiting, has it ever been discussed to have home visitors interface with women during their prenatal care so that they're more likely to accept home visiting, since the rates were only 50%? And then I'll just quickly ask the next question and then let you both speak. And then Nneka, specifically to doula care, I was at a delivery last week with a woman who had a baby by herself, and I was blown away. I had to lead the delivery despite the fact the anesthesiologist is going to lose her mind because this woman had HELP syndrome, and I'm trying to find somebody who can come in here to the hospital and be with her for this delivery. And I found out afterwards that the Brigham does have a doula center, a service for women, but it wasn't advertised, and so I didn't know how to, even if I would have known beforehand, I wouldn't have known how to use it in that way. And so as I put in a plug for part of the conversation we're going to have tomorrow, my question to you is, the Reed Scholars tomorrow are going to be talking a little about digital health, and I haven't heard in any of our conversations where technology plays a role in this, and I'm wondering if there are apps or something related to doula services so that we can have a better conversation of knowing how to help connect women to people who want to be connected to them to support them. So I'll let you answer, Karin, and then come back to Nneka.
Sure. Some of the home visiting programs are really community health workers, and they don't consider themselves community health workers so much as peer support. They're paraprofessionals. They receive extensive training in motivational interviewing and working with families. And yes, they do connect with them in pregnancy. And yes, their role really is to link with the prenatal care provider. One of the home visiting, our homegrown home visiting, there's a nurse, there's a mental health provider or a social worker, and a community health worker, and the nurse does a lot of that linking around with around the issue of pregnancy and who do they want when they're in labor, and connecting them with the doula. And in fact, one of the programs, the EIPP program in Somerville, connects with the Cambridge Health Alliance doula program and really tries to work with the doulas to get them hooked up. So they do. I think it really helps a lot of people to have a nurse on the home visiting team, because sometimes, they want, let's see, how do I phrase this? Sometimes they really want someone who can interpret the medical system in a way that they feel heard, tell me about what hypertension is. Tell me about, they threw this word at me and that word. And, having a clinical person on the home visiting team really helps with that translation. So, yep, I'd love to have, again, looking to our international partners, I'd love to have universal home visiting for everyone, prenatally up through 5 years of age. But
to sort of respond, we are seeking a doula. We currently have a doula bill in the House, and we're tweaking that a little bit to reflect not only birth, but postpartum and bereavement support. So I'll be meeting with someone in a couple of weeks so that we can add in a specific amount of pay, so that not only will parents who are on Medicaid, Medicare, whichever, thank you, be supported via birth, but also throughout the first 40 days postpartum. In response to the technological support, we do have a Mass Doulas, I don't want to say website, but since you're in the Boston area, we do have sort of a hotline through BASC, and I will make sure that the information is provided. I'll send email the information as soon as I get home. Different information, because it reaches the Mass Doula's email, or we have like this Google group where if someone needs a low cost or free doula, or if someone can afford to pay, it's posted in this group, tells the person when they're giving birth, where they're giving birth, etc., and we just respond as needed. But for an emergency situation, you should have been able to contact Anastasia at the Brigham and say, we need someone now, and someone should have been there. Ideally, we would follow the Brooklyn, New York Public Health Commission, where they have a doula program that's built into their Public Health Commission, and hopefully we'll get there. I'd love to see a postpartum doula program to support a family, not just with 1 to 3 visits, but with the first 40 days postpartum to a year. And with this doula bill, that can happen because insurance will pay, and we don't have to find funding to support that. Does that answer your question? Okay.
Other questions? Do you have another one? Is that what you were going to say?
Thank you very much. Actually, I wanted to follow back. I really appreciate the question about, like, do we have to look for providers that will take care of me as a human being? And I think my question, and it sparked my thinking, and I love the fact of the cultural humility concept of as provider and also as a human being. What is more important? Do I need to seek a racially congruent provider or a culturally congruent provider if we're all human beings? And I just feel that the concept of like racial differences, we don't choose that. But cultural differences, we can get trained, we should be able to embrace. And that is the opportunity of change, instead of like probably reinforcing a little bit more toward racial segregation. So I don't know if I can hear a little bit more about how you think, I really appreciate you nodding your head, like the doulas and thing. And like, for example, my patient, I was raised Hispanic, and when the patient come in, they ask for La Chinita. And that feels very, like, probably for people who feel like she has a name, but having a name does not make you be identified. But being called La Chinita, that they has the freedom to call me like that, that is what helped me be identified with them. And like, I would love to hear from the panel and also from the audience about the cultural congruence of provider with patients. Thanks.
I can say something about cultural congruence really quickly. So there have been some studies that have been done that look at gender, they look at race, they look at socioeconomics, they look at linguistic concordance, and they look at all of these things. And while all of those are very important, and there's a number of studies that will show that there are certainly increased adherence to medications, perhaps some of them, the ones that have been touted most frequently, this is a lot of Lisa Cooper's work, where they're looking at diastolic and systolic blood pressure numbers with concordance and finger sticks and things like that. But I think that the other piece, the body of literature, speaks to creating these spaces for both cultural humility, cultural appreciation, and flattening of power dynamics. And I think the way that at least the AAMC, the Association of American Medical Colleges, is looking at it right now is around this idea of curricula around racism and advocacy, and in medical school trying to address how it is that we begin to teach students The history of the impact of racism, discrimination, socioeconomics, politics such as redlining, policy and legislation on health outcomes. And if we are able to begin to educate medical students about that, we would then cultivate a generation of physicians where concordance matters less, significantly less, because they are coming in with a very clear understanding of how what they are bringing to the room and how the patient, and what patients bring to the room impacts that interaction in the context of the history of racism, discrimination, socioeconomics, geographics, immigrant status, gender, sexual orientation, and all of the things that we know play a significant role in increasing distrust. And honestly, not only distrust, but misunderstanding between providers and patients. And then you actually probably, Dr. Molina, has something to say too, as well as Dayna. Do you want to say something?
Oh, I'm sorry. The short that way. I was just going to say, like, as a public health professional, I'd say that exact same thing sort of is happening. You know, in the earlier days of my training, we heard really nothing about racism and discrimination, and you know, now it's sort of a buzzword, and students are getting it earlier and earlier, and I think it is extremely important because some of the policies, some of the practices have some overtly racist tones to them, and some, you know, underground sort of racial tones to them, racism tones to them as well, and so the distrust between community and provider community and public health professional, whoever is there, and so until we start getting that information out, I think, and putting it into training programs, we're going to be in the same situation. And I think race concordance is extremely important, but I don't think, I agree with you that I think if people are beginning to understand that everybody's people aren't coming at it from a racist perspective, then that trust will be there regardless.
Other comments?
There's a program out of the Community Training Institute that teaches, I was recently a part of a cohort there that really delved into racism and how it starts, how it forms, how it keeps going, and then how to break it down. I mean, I've been Black my entire life, and I had never seen anything like that in my life, and I went home and was blown away, and I've been putting things in like little triangles ever since. But that's a good place to start, getting trainings like that into facilities to help people see that even though they're Black, they still have these biases towards other Black people, and so on and so forth. So that's an excellent place to start. And also looking at models around the United States that work, such as Jenny Joseph's model out in Orlando. I'm trying to bring her here for her community health training in October. So be on the lookout for that, because she has recently rolled out a model that helps to put together, it helps us to get a feel for her her centered-based program out of Orlando, and she's sharing that knowledge, and I can't wait until she gets here because it's so very needed here in the Boston community.
So we have 2 minutes. You have a very short question with a very short answer, maybe?
I do.
Oh yeah, you can control that.
A few people today have brought up the importance of having more reproductive options available to women. And full disclosure, I almost died 2 years ago from side effects from birth control pills. And I know a young lady that died 3 weeks ago, 24-year-old, from pulmonary embolism from birth control pills. And we know that many of the same factors that increase rates for maternal health mortality rates also increase side effects to birth control options. And just in the discussion today, I don't want people to leave thinking that reproduction is the solution, and making sure that we take a holistic approach to this issue.